Thank all the chairpersons for this introduction. And I would like to speak on fertility preservation in cancer patients. And I think being president-elect of the society, we visited many cancer institutes and had an interview with the oncologist. And Gautam helped us in having an interview with the oncologist here at Tata Cancer Hospital. And we have included everyone's views wherein we have published the recommendations for fertility preservation in cancer patients. And it would be also available on the website of the Oncofertility Journal. So why should we preserve fertility? We know that there is an increased incidence of cancer during the reproductive age, and the majority of the young patients diagnosed with cancer will become long-term cancer survivors due to improved survival as well as cure rates of cancer. Many of the survivors will also become infertile due to the treatment if they have not undergone fertility preservation, and the ability to start a family and have a child is the key quality of life issues in cancer survivors. We know that radiotherapy and chemotherapy are both gonadotoxic in the male as well as the female, and it depends basically on the age, the medications used, as well as the dosage of the medications, as well as the radiotherapy. After treatment, in the male, we could have oligospermia or azoospermia, whereas in the female, we can have irregular menstrual cycle, premature ovarian failure, and infertility. And the methods used basically will depend upon the age, the type, and the dose of the adjuvant therapy, the time available before chemo or radiotherapy, as well as the length of delaying the childbearing post-chemotherapy and radiotherapy. And most papers have said, and there's evidence that pregnancy is usually recommended 2 years after chemotherapy. All of us are aware of the initial treatment planned, but the final treatment course is really not known as to what the survival is going to be. And there are certain issues that need to be addressed before advising fertility preservation. And one of the most important is the oncological prognosis and the quality of life post-treatment, the fertility and the past obstetric history, the availability and reliability of the fertility preservation technologies, the surgical modalities and expertise and cost of storage, the fate of the gametes in the event of death, screening for viral disease, explaining the meaning of success, that is, even if you have preserved your fertility, what would be the success rate, or what is the chance of the patient having a baby. The psychosocial perspective, again, is very important, and it's important that we do an individual counseling as well as we do parent and couple counseling. Parent when the fertility preservation is related to pre-pubertal and pubertal adolescent children. And most important is getting an informed consent. If you look at the effect of radio and chemotherapy in the male, we know that if there is damage to the spermatogonal stem cells, then there is usually a permanent azoospermia. But if there is damage to the differentiating germ cells, then basically there is a transient azoospermia, and usually it really does not affect.
Excuse me. Can you check the projection, please?
It does not affect the.
Okay.
It does not basically affect the Leydig cells, and therefore the testosterone levels are usually not affected unless it is used in a very high dose. So once it is diagnosed, basically it's very difficult to evaluate the germinal damage because the testosterone levels usually do not change and the secondary sexual characters are also not affected. Basically what is required is a semen analysis, and it has also been observed that some of these men resume spermatogenesis spontaneously, and the damage to the gonads is different in the pre as well as the post-pubertal males. So if you look at the fertility preservation options, in the adults, we know that sperm cryopreservation is an established option, whereas cryopreservation of sperms obtained by surgical techniques as well as by electroejaculation, and from the post-masturbation urine samples is still experimental, and there are only small case reports. Testicular tissue cryopreservation has been done, but there's no reimplantation which has been done in humans, and basically there are only animal studies which are there, and there is no evidence for using hormonal therapy. But when it comes to children and adolescents, we know that in the pubertal, we can still do semen cryopreservation, and gonadal shielding is also possible, but again, there are only case studies. In the prepubertal, probably gonadal shielding may be helpful, though there are a few case studies which have been published, but testicular tissue cryopreservation is not being tested in humans and is still experimental. The risk of, and it's important that the semen cryopreservation should be done before initiating chemotherapy, otherwise there's increased incidence of aneuploidy, DNA damage, as well as gene mutations. And cryopreservation can also result in ice crystallization and osmotic and chilling injuries resulting in cytoplasmic fracture, and they could also have an effect on the cytoskeleton and on the genome-related structures. In azoospermic wen, wherein we need to go for fertility preservation, we could either attain sperms by vasal aspiration or epididymal aspiration or using testicular sperm extraction. When we talk about testicular tissue freezing, though it is technically feasible in both pre- and post-pubertal males, but one must have a transplantation protocol as well as a storage protocol, and its reproductive efficiency and safety has still not yet been proven. When we talk about the safety concerns of autologous testicular transplant in humans, we need to think about the reintroduction of malignancy. We know that a surgery is required, infection may result, and there's not much known about the epigenetic stability of the germ cells after testicular freezing, and they could be damaged by cryopreservation, dissociation, culture, or transplantation. And as I said earlier, there are no reports yet in the humans. Coming to the impact of chemo and radiotherapy in the female patient, chemotherapy can result in direct ovarian toxicity, vascular toxicity, and it can also have cellular effects wherein it can affect the cytoskeleton, it could cause DNA damage as well as oxidative stress. And one must remember that radiotherapy does not only affect the ovaries, but it can also affect the uterus, and therefore it can result in decreased implantation rates and also premature births. So when we talk about the risk of infertility, we should know that there are certain chemotherapeutic agents which have which are definitely associated with ovarian damage, and these include nitrogen musters, that is basically all the alkylating agents, and also procarbazine and dacarbazine, whereas those probably associated with ovarian damage are vinblastine and cisplatinum, as well as some group of alkylating agents. Whereas those having low probability of ovarian damage include methotrexate, 5-fluorouracil, 6-mercaptopurine, vincristine, and mitomycin. And still, there are no studies which are related to drugs like VM26, danirubicin, bleomycin, as well as doxorubicin. So basically, we should use them with care and probably think that they might cause problems. The fertility preservation in women is a personalized medical therapy, and one-size-fits-all approach does not exist. And therefore, every woman, a multidisciplinary group of experts should convene and analyze all the related issues prior to recommending the best option for particular patient and spouse. Thus, identifying and selecting the female patient with cancer to whom we can offer fertility preservation depends upon a variety of factors, each with a significant as well as unique importance. And these therapies should be tailored according to the patient's age, type of the disease, spread of the disease, planned treatment, time available, and also whether the patient has a partner or not. And when we look at the main objectives of fertility preservation in these oncological patients, the special targets what we need to include are to determine the ovarian reserve before and after treatment, to determine the effect of cancer on the ovarian function, and also to detect metastasis in the frozen ovarian cortex. So when we talk about the fertility risk factors, the intrinsic factors include the health of the patient now, when we are going to do the fertility preservation, and also after the treatment, the age of the patient, and it's important to assess the ovarian reserve, and it can be done by using clinical parameters like the menstrual cycle, lab parameters like evaluating the FSH and AMH, of which AMH is a better option, and by ultrasound where we look at the antral follicular count. There are certain other extrinsic factors which we need to look at, and this includes the nature of predicted treatment, whether we are using high, medium, or low risk drugs, the practicalities of fertility preservation, as well as the time, expertise, and the funding which is available for the patient. And the most important thing what we need to remember is that resumption of menstruation post-chemotherapy does not mean that fertility has been preserved. Then the second question is whether the ovarian reserve is affected by cancer, and this is very controversial. There are patients wherein the ovarian reserve can decrease, and this is basically seen in those patients who are BRCA positive, and those who have lymphomas and childhood leukemias, and those who have undergone ovarian surgery, wherein a lot of cortical tissue has been reduced. And this decrease in the ovarian reserve is basically related to the poor general health, increased catabolic state and malnutrition, stress of having cancer, as well as impaired granulosa cell function. And there are others, and we know in most of the other cancers, the ovarian reserve is not reduced, and basically age is significantly associated with the number of oocytes retrieved. And it has also been observed that more in patients who undergo fertility preservation in cancer patients have more immature oocytes, and they have less number of M2 oocytes, and as compared to social freezing. Coming to the risk of ovarian metastasis in different types of cancer, basically you can see the cancers which have a very high risk of ovarian involvement are neuroblastomas, leukemias, Burkitt's lymphoma, fallopian tube cancer, and poorly differentiated ovarian cancer with contralateral involvement and the presence of malignant cells in the ascitic fluid. Whereas cancers which have a very low risk are Wilms tumor, Ewing's tumor, breast cancer stage 1 to 3, which is an infiltrative ductal histological subtype, non-Hodgkin's and Hodgkin's lymphoma, non-genital rhabdosarcomas, osteogenic sarcomas, squamous cell carcinoma of the cervix, as well as endometriotic type of endometrial carcinomas. And those with moderate risk of ovarian involvement are adenocarcinoma and adenosquamous carcinoma of the cervix, colon carcinoma, endometrial cancer with more than 50% of myometrial invasion, breast cancer stage 4, which are basically infiltrative lobular histological subtype. Coming to the options of fertility preservation, basically we know that if the patient is at fertility risk, and if you have a prepubertal one, the ovarian tissue biopsy with ovarian tissue cryopreservation is the only option. But if the lady is postpubertal and we have time to undergo ovarian stimulation, then we could either freeze the oocytes or we could freeze the embryos. But if there is no time, we can do an immature oocyte retrieval with in vitro maturation and freeze the oocytes, or we could go for ovarian tissue cryopreservation along with in vitro maturation of the oocytes which are obtained during dissection of the ovarian tissue. Ovariopexy during pelvic irradiation is one of the options, GnRH before and with chemotherapy, and fertility sparing surgery in early stages of cancer cervix, endometrium, and ovary is possible. And if you have high risk of involvement of the ovarian tissue, then one could go for ovarian tissue cryopreservation, but we need to do either in vitro maturation of the oocytes obtained when you do an ovarian tissue biopsy or a xenografting, and all the other methods are basically applicable only in those patients who have a low risk of ovarian involvement. We know that oocyte and embryo cryopreservation are the established methods of ART, and we have been doing it for the long time, so we can see that those are the best methods of fertility preservation. But we also know that it requires time for hormonal stimulation, and the patient has to undergo transvaginal ultrasound as well as transvaginal retrieval, which may be a problem in patients who are in the adolescent age group. oocyte cryopreservation, and it's important that we perform it only in those centers who have adequate expertise, because ovarian oocyte cryopreservation is quite different from embryo cryopreservation, and the fertility or the implantation rate post ovarian cryopreservation after we have thawed the oocytes is much less. And the most important thing which has come to our rescue today is the random start ovarian stimulation protocol, so that we can start the stimulation at any time of the menstrual cycle. And to enhance the cumulative live birth rate per oocyte retrieval, we need to have efficient cryopreservation program for oocytes and embryos, and the vitrification is basically the best technique for cryopreservation. And when we talk about embryo cryopreservation, we should not freeze embryos who have more than 30% fragmentation, who have multinucleated blastomeres, have a slow cleavage rate, or when you are freezing a blastocyst, they have a small ICM or few and large and sparse trophoectoderm cells. And during oocyte freezing, it's important to determine the abnormalities of the perivitelline space, cytoplasmic clarity, zonal thickness, integrity of the first polar body, and absence of vacuolization before we freeze the oocytes, because as I've already said, the survival rate of the oocytes is much less than that of the ovaries. The advantage of oocyte vitrification is that now it's no longer experimental, we know, and vitrification has resulted in efficient oocyte freezing, and we can use a random start protocol. There's no impact on the ovarian reserve, and it's less invasive and more efficient as compared to ovarian tissue freezing, and it also enables surrogacy. But we know that it can be done only after post-puberty. It's impossible to be done when we have an emergency, when we do not have time. It requires presence of antral follicles and a transvaginal retrieval. At times, it could be a poor response, and we could obtain very few eggs. And high E2 levels can also affect the cancer status, and therefore, there's a limited number of oocytes that could be frozen. And it institutes only the reproductive function and not the endocrine function. And the problems basically in adolescents with oocyte cryopreservation is its pubertal status, virginity, which allows suboptimal ultrasound monitoring and a transvaginal pickup, the follicular ovarian status, and it's important that the parents also need to give a consent along with the patient, and the choice of the starting dose may be a problem, basically because the AMH and the antral follicular count is really not suggestive of the ovarian reserve, and high estrogen levels during COS can also affect the bone growth. And this paper published in 2018, we can see that they obtained good number of oocytes as well as mature oocytes if the age of the patient was in any way above 14 years. This was another paper in 2019 which looked at the mature oocytes obtained in premenarchal and postmenarchal girls, that is a period around puberty, and they found that more mature oocytes were obtained in postmenarchal women, and even the rate of in vitro maturation of the oocytes was much higher in postmenarchal women. We can also do immature oocyte retrieval with freezing of the in vitro mature oocytes, which could be obtained by either ultrasound guided aspiration or from a oophorectomized ovary or from a ovarian biopsy specimen. And you can see these are all immature oocytes which can then be matured in vitro. And if we compare IVF versus IVM, in the IVM fertility preservation group, the maturation rate after 48 hours was only about 58%, and the number of M2 oocytes were also significantly lower, as you can see over here, and the number of oocytes and embryos cryopreserved were also significantly lower. And in this paper, which was published in 2019, though healthy live births have been reported after IVM, basically in PCOS patients, but there are no papers or there are no reports about IVM in cancer patients. The efficiency of IVM oocyte cryopreservation is still low and requires further improvement in the technique, and the improved understanding basically will affect. Coming to ovarian cortex cryopreservation, we know we can remove the ovarian cortex and freeze the cortical tissue, and basically we can then re-implant it, and basically it is indicated when there's immediate therapy required and in pubertal girls. It allows to preserve the steroidogenic as well as the reproductive function, and it can be performed at any time of the menstrual cycle, and it allows to retrieve a high number of primordial follicles. But selection criteria for ovarian tissue cryopreservation is very important and it has to be done only if the age is less than 35 or if you have a good AMH value. And you need to do it before chemotherapy and when there is no contraindication for surgery or anesthesia. The advantages is that, as I told you already, that it reinstitutes the endocrine and exocrine ovarian function. The method of choice is before puberty and possibly when you do not have time and there's no high estrogen levels and vaginal procedure which is required. And it can also be combined with IVM. And we talk about the drawbacks. It requires a surgical procedure and there's risk of malignant cell reintroduction with and there could also be follicular loss after grafting. And we can see over here that there's reinstitution of the ovarian endocrine function with the FSH levels coming down. There's also induction of puberty when it is done in prepubertal girls. And we can see till the last paper published in 2019, there have been 185 live birth rates. And most of them, almost 50% of them, you can see the live birth rates as well as the method of achieving pregnancy is spontaneously, and the remaining 35 to 40 is by IVF. And most of these births have been by slow freezing. And this was only one meta-analysis which compared slow freezing versus vitrification. And in this paper, they found that there was no difference in the proportion of intact primordial follicles as well as the primordial follicular density when slow and vitrification was compared. But the DNA fragmentation was much less with vitrification, and the number of stromal cells were also higher post-vitrification. Live births also have been reported with ovarian tissue transplantation in prepubertal as well as postpubertal girls. We can also use GnRH analogs as it protects the ovary by mimicking a prepubertal status where it decreases the FSH as well as the growing follicles. It decreases the uterine ovarian perfusion as well as ovarian exposure to chemotherapy. And it also has a direct effect, anti-apoptotic effect on the cumulus cells and prevents the activation of the primordial follicles. And it should be considered as a reliable strategy to preserve ovarian function and fertility. And basically, though the data is conflicting, safety and efficacy has been demonstrated in patients with breast cancer, and there's also been pregnancies post that, and there's no impact on the disease-free survival. Whereas in other malignancies, though it has protected the ovaries, no pregnancies have still been reported, and it is also associated with the reduced risk of induced POI in patients with lymphoma, non-Hodgkin's and non-Hodgkin's lymphoma, with a pregnancy rate of about 57%. But there was no increase in pregnancy rate in patients with hematological malignancies, and therefore it could be used in situations where proven methods cannot be used. However, we require further studies. We can protect the ovaries by oophoropexy from pelvic irradiation, and the ovarian protection is about 86%, and pregnancies have been reported. But the protection is 50% because there could be spontaneous ovarian relocation, scattering of irradiation, as well as decreased ovarian supply. And at the time of transposition, one could also have an option of doing ovarian tissue cryopreservation. Apart from the fertility preservation procedures, fertility sparing surgeries also can be offered in early stages of CA cervix, endometrium, and ovaries. In cervical cancer, where you have stage 1, A1 and A2, or stage 1B and 2A, where the sentinel node is negative, we can go for conization or simple or radical trachelectomy. In endometrial cancer type 1, stage 1, grade 1, we can go for medical therapy with progesterone. In patients with bilateral borderline ovarian tumors, especially when in early stages, we can go for cystectomy, either unilateral or bilateral, or unilateral salpingo-oophorectomy. And once the patient conceives, they can undergo a salpingo-oophorectomy. For vulvar and vaginal cancers, wide excision in the early vulval cancer is possible, whereas fallopian tube cancers, basically, fertility preservation is not observed. Coming to fertility preservation in children, it is limited by sexual immaturity, and the methods, as I told you, just include gonadal tissue cryopreservation. Neotherapies can use gametes from the stem cells, as well as regeneration of the reproductive organs by using stem cells. And uterine transplant is one of the options, though there have been pregnancies which have been reported, but we also need to take into consideration the advantages and disadvantages, and so far about 19 children have been born. Coming to the safety after fertility preservation for both mother and child, it has been shown that there's no detectable increased risk and disease recurrence with most fertility preservation methods and pregnancy, even in hormonally sensitive tumors. Cancer treatments has mutagenic effect on the oocyte present in the growing follicles, and the risk is related basically to the stage of oocyte development during the exposure and the drug regimen that has been used. And cancer therapy or fertility preservation does not increase the risk of cancer, chromosomal abnormalities, congenital abnormalities, or fetal malformations in the offsprings if the conception happens 1 year after the cessation of treatment. And basically, it requires an interdisciplinary team approach, which involves the medical and the surgical oncologist, the reproductive endocrinologist, the counselor, a social worker, as well as a researcher when we are implementing newer techniques. And therefore, at cancer diagnosis, after the oncology consultation and the treatment plan is decided, and if there is risk of fertility, one should refer them to a fertility preservation program. And once they consult, they could either undergo the procedure or undergo expected management and then start treatment. Counseling and information are very important to increase the knowledge as well as the satisfaction, and they help in decision making, decreasing the decisional conflict as well as decreasing the decisional regret. And I would like to conclude by saying that assessment of risk for infertility, communication with the patient is important. Patients at risk of treatment-induced infertility and those interested in fertility preservation options should be referred to a specialist with expertise in fertility preservation methods. And if they are eligible, in the male, we know that the only established technique is sperm cryopreservation. In the female, we could cryopreserve either the embryos, oocytes, and also the ovarian tissue. They could go for conservative gynecological surgery and undergo an oophoropexy, whereas investigational fertility preservation techniques are cryopreservation of the testicular tissue as well as ovarian suspension. And our motto basically is to preserve hope in these cancer patients, and I thank you all for a patient hearing.